Spin Essentials, the core topics in pediatric neuroimaging essential for daily practice, packaged as our holiday gift to you.
Hello, everyone. I'm Matthew Whitehead from Children's Hospital of Philadelphia. Today we're going to talk about hindbrain malformations. I have no disclosures. So let's review some anatomy, embryology, histology, and physiology of the hindbrain to provide you with some context that I hope will enhance your understanding of hindbrain malformations. Beginning with anatomy, in the first gestational month, just after the rostral neural pore closes, the rostral neural tube will differentiate into three primary vesicles, the prosencephalon, the mesencephalon, and our area of interest today, the rhombencephalon, where the prosencephalon will continue to differentiate into the telencephalon and diencephalon, and the mesencephalon will ultimately form the midbrain, and the rhombencephalon will form the medencephalon above and the myelencephalon below, and the medencephalon continues to form the pons and cerebellum, where the myelencephalon forms the medulla. This, patterning process really lays the ground plan for brain substructure segmentation. But if the process goes awry, you can end up with disproportionate size of brain regions. And to show you what I mean, here I've simulated three different types of patterning defects causing hindbrain malproportions. In the first case, we can see an elongation of the midbrain and a shortening of the pons and vermis. Opposite that, in the second case, we have elongation of the pons and vermis and a shortened, truncated appearing midbrain. And in the third case, we see loss of the pontomedullary distinction, the pontomedullary sulcus here. And all of these could be considered antero-posterior or AP patterning defects. But this could be a bit confusing, at first glance, considering the anatomy of the upright human brain. But pretend you're a dog. The AP, or anteroposterior axis, is akin to the rostrocaudal axis and opposite the ventrodorsal axis. So AP translates to rostrocaudal and ventrodorsal translates to AP for human neuroanatomy. Now, let's look at some more specific substructures of the brain. The sagittal T1 weighted image and coronal T2 weighted images nicely show normal posterior fossa anatomy. The midbrain to pons to medulla ratio is at least 1 to 1.5 to 1. The back of the brainstem and front of the vermis are roughly parallel to one another. This is the tegmental-vermian angle. The fastigial recess of the fourth ventricle here is sharp, shaped by the nodulus located just below the midpoint of the pons. If you draw a line from the fastigial point here through the primary fissure, this breaks the vermis down into a roughly 2 to 1 ratio below versus above that line, and a mature vermis extends from approximately the mid-tectal plate to the level of the obex. The occipital bone is seen here, closely approximating the undersurface of the cerebellum, leaving only this small cisternal space, which is less than 10 millimeters in most normal scenarios, the cisterna magna. In the coronal plane, we can see the hemispheres laterally and the vermis in midline. Now, the primary fissure and the posterolateral fissures divide the cerebellum into three broad regions and functional areas. The anterior lobe, seen here and here, and these are components of the spinocerebellum, so they're sensoromotor, movement coordination, posture, and tone. And notice how the anterior cerebellum is mostly the vermis and also contains a little bit of the superior quadrangular lobe and the paramedian cerebellar hemispheres here. The posterior lobe is also called the neocerebellum, and that's mostly cognitive, social, emotional, behavioral processing are its assigned functions. It is separated from the anterior vermis by the primary fissure. And then you have the flocculonodular lobes here, which is separated from the posterior vermis by the posterolateral fissure. The flocculonodular lobe, also called the vestibular cerebellum, is responsible for equilibrium, eye movements, and adjusting reflexes. You can see it here in the axial plane. Now, in the coronal and sagittal planes, you should pay attention to your horizontal fissure here, which separates two big components of lobule 7. 7A is Crus 1 and 2. And so you can see those in the coronal plane and in the sagittal plane. And the Crus 1 here points towards your transverse sinus. That's how you find it. The petroclival fissure is just above, separating Crus 1 from lobule 6 above. Now, these are very important functional parts of the cerebellum, and that's why I sort of bring it up here because the right side of the cerebellar hemisphere, especially Crus 1 and 2, play a role in language in patients with left dominant cerebral hemispheres, and the left Crus 1 and 2 play a role in visual spatial processing and connect to the right parietal region, among other locations. Now, what should we see on field MRI? Well, by 18 weeks, assuming you have relatively motion-free images in the sagittal midline plane, you should see a sharp vestigial point of the fourth ventricle, a defined primary fissure there, and a small tegmentovermian angle, which should be less than 12 degrees at this point. And the fourth ventricular roof should be covered. And on 1.5 Tesla MRI, by 22 weeks, you should really see all 7 Vermian lobules. And so the first 3, 1, 2, and 3, are part of the anterior vermis here. There's the primary fissure. And now 4 is actually what people call the DFT because it's comprised of the declive, folium, and tuber. We can't really separate those out usually on fetal imaging. If you do, it's sort of later in gestation, the DFT there. And then lobules 5, 6, and 7, 7 being the nodulus. But if you look closely and you have decent imaging in the midline, you should be able to pick out all 7 lobules by 22 weeks. And then in the axial and coronal planes, I'd like to be able to look for the vermis, which looks separate from the hemispheres, and I call that sort of the speed bump sign and the bow tie knot sign in its appearance there. Now, you can employ diffusion tensor imaging to provide, you the opportunity to evaluate the size, the direction, and integrity of white matter tracks. What I'm showing is the directionally encoded color map from the DTI, and this contains information regarding white matter anisotropy, both the signal magnitude and directionality, the color hue, where by convention we see blue skies or fibers running in the craniocaudal dimension, for instance, the corticospinal tracts, corticobulbar tracts here, the central tegmental tracts, medial and lateral lemnisci, and spinal thalamic tracts, and the inferior cerebellar peduncle here posteriorly. And we see green pastures, fibers running in the AP direction, like the middle cerebellar peduncle fibers. And we see stop signs, fibers running left to right, like the pontocerebellar fibers here. Okay, with that background, let's cover some malformations. Okay, so first we need to be on the same page in terms of the definitions of what a malformation is. So since Merriam-Webster Medical Dictionary defines dysplasia and malformation in a relatively similar manner, an Oxford Medical Dictionary considers dysplasia a premalignant condition. I'm going to stick to the term malformation to describe disorders, congenital disorders of the brain and that alters the shape. Hyperplasia is an increase in elements composing a part, where hypoplasia is arrested development. And when we're talking about the cerebellum, we mean that it is small in size with normal size fissures, as opposed to volume loss, where there's decrease in volume of the cerebellum over time with widened fissures. Right. So I like to use a simplified imaging base, way to evaluate hindbrain malformation. And this begins with classifying the dominant posterior fossa abnormality as either hypoplasia, hyperplasia, or malformation. Considering both the cerebellum and brainstem together, and also, realizing that these are not standalone structures and should always be evaluated in the context of what's happening with the rest of the brain and body for that matter. All right, so if you have a cerebellum or brainstem that is too big, the next order of business is to determine if it is isolated or if it is part of diffuse brain enlargement, as in these 2 syndromic examples that I'm going to show here. In both, the cerebellum is overgrown and the hemispheres fill the usually unoccupied vallecula with tonsillar extension into the foramen magnum, right? Now, additional clues to help distinguish these syndromes are the hyperintensities on T2-weighted images in the globi pallidi and the thalami and the deep cerebellum here on the left in this patient with neurofibromatosis type 1. And on the right, we have enlarged perivascular spaces and perisylvian and frontoinsular polymicrogyria. You can see the gyral sulcal pattern is quite increased in these regions compared to the more normal gyrocycle pattern more posteriorly in the hemispheres here. So this is a case of a P10 mutation, which is a regulator of cell division and tumor suppressor gene. Now, visual assessment of the brain size can be difficult, so I recommend keeping a low threshold for comparison to age-matched normative data and any literature available, such as this. For instance, the 2-year-old boy with NF1 that I showed on the previous slide, the vermis and pons were all both larger than the 97th percentile for age. Okay, a cerebellum that is hypoplastic can either be diffusely hypoplastic, vermian, or hemispheric predominant. Here are two different forms of cerebellar hypoplasia. On the left, there's hypoplasia of the cerebellum uh, and brainstem, and really the entire posterior fossa. Look at the downward slanting of the straight sinus. Um, so when you see these changes in a patient that has a fairly unaffected cerebrum, and especially if you see preferential involvement or sparing of structures. So, like in this case, we have more involvement of the vermis than the hemispheres. Here we have more involvement of the hemispheres than the vermis. These are called the butterfly sign and the dragonfly sign, respectively. So, together, really think hard about genetic pontocerebellar hypoplasias. Now, you don't always have preferential involvement of the vermis or hemispheres in these. You can have a diffuse symmetric hypoplasia, but when you see that, strongly suggest pontocerebellar hypoplasia. On the right, the fastigial recess here we see is rounded rather than sharp, and we have this sort of radiating fissures and folia, unlike the fern-like appearance of a normal vermis with a sharp fastigial recess. Here's the appearance of normal in the coronal plane, and we see midline hemispheric union across midline that kind of looks like the duck bill of a duck, right? So this has been called the Donald Duck sign in a patient with rhombencephalosynapsis. So there's really no vermis present here. What you're seeing in the midline is hemispheric union, rhombencephalosynapsis. But probably the most common cause of pontocerebellar hypoplasia is going to be a prematurity related injury. So, go back and take a look at the history always, look for other imaging clues to suggest the diagnosis. Here we can see a posterior predominant gliosis and necrosis. Here, thinning of the splenium and white matter signal changes, white matter injury of prematurity here. We also see that there's encephalomalacia and gliosis in the paramedian cerebellum here. Look at the widened fissures and bright signal on the T2 flare sequence and in the coronal plane that somewhat spares the vermis. This is what I call the injured dragonfly sign. Now, you may or may not see susceptibility from prior hemorrhage. This could be ischemic. It can be from prior bleeding. Blood products in the cerebellum tend to be resorbed over time. So lack of any susceptibility doesn't exclude prematurity-related injury. Okay, so here are two different patients that presented both with bilateral abducens nerve palsies. The first thing you should think about and rule out with this history is intracranial hypertension, as raised intracranial pressure can stretch and secondarily cause dysfunction of the cisternal segments of the abducens nerves. This is called the false localizing sign. And when this is ruled out, then next you want to follow the expected course of the abducens nerves from the brainstem, pontomedullary junction, through the cisternal segments, Dorel's canal, cavernous sinus, orbital fissure, orbit, lateral rectus muscle, right? So we know the abducens muscles innervate the lateral rectus muscles, and here we can see in both cases the lateral rectus muscles look a little thin compared to the medial rectus muscles, and the ocular globes appear to be sort of deviating inwards, so esotropia bilaterally. So, okay, so now we want to look at the abducens nerves if we can see them. This is a case where you might add a high resolution 3D image to be able to see the course of the nerve. But if you do 3D T1 weighted images, as we can see here, you should still be able to see the abducens nerves in most scenarios. Here's a normal case. So parasagittal plane, pontomedullary junction, you should see ascending in the pontomedullary junction, a thin linear area of intermediate signal. This is the abducens nerve heading towards Dorel's canal. Here it's absent on the left and it's absent on the right. So both patients have no bilateral abducens nerves on either side. Now, in the left case, we also see, looking at the other cranial nerves, that there are no other cranial nerves that are absent. We can see this is looking down the barrel of the internal auditory canal. anterior, posterior, superior, inferior. We see the facial nerve in the anterior superior part of the canal, the cochlear nerve in the anterior inferior part of the canal. This is your 7 up, coke down appearance. The superior and inferior vestibular nerves posteriorly. So this is kind of a normal appearance. But if I tell you that this patient had retraction of the globes on attempted adduction at birth and this appearance, then this is consistent with Duane syndrome, and this is an autosomal dominant disorder. In the latter case, if you look closely at the back of the pons, we don't see the facial colliculi as we do here at the midpoint of the pons where the trigeminal nerves are coursing. We should see these two little nodules. We don't see them here. The facial colliculi are absent. So that tends to be a bad sign. Let's look in the internal carotid IACs here. We see that there is a cochlear nerve, but there's no facial nerve, and the vestibular nerves look to be in union together. All right, this is a case of Mobius syndrome, and Mobius syndrome can be genetic, can be sporadic, or it can be acquired from a prior insult. But both of these are considered to be due to hypoplasia secondary to dorsoventral patterning defects or misspecification of germinal zones. Okay, on to malformations. These can be focal, regional, or diffuse. For the focal malformations, here are two 5-year-olds with genetic causes of focal cerebellar malformations. On the left, some people would consider this a, quote, cerebellar dysplasia, but we have just extensive architectural distortion of the left cerebellar hemisphere, multifocal hyperintensities on the T2-weighted images in the deep cerebellum, thickening of the chiasm. Together, this is consistent with NF1. Now, malformations are rare in NF1 in the cerebellar hemispheres, but if you do see them, they tend to be seen with patients with large deletions. In the next case, we see these peripheral wedge-shaped areas of increased signal in the cortex and white matter on the flare sequence. If you saw one of these in the cerebrum, you'd call it a focal cortical dysplasia. If you saw many of them, you'd call this tuberous sclerosis. And in fact, that's what this is. This patient had multiple cortical tubers, white matter lesions, subependymal nodules, and cerebellar lesions consistent with tuberous sclerosis. Now, you know, the cerebellum is unusually involved with TS, but when you do see it, this should indicate the TSC2 gene abnormality or variant. So that's quite specific as opposed to the TSC1, which tends to spare the cerebellum. The other thing about these is they tend to change or can change over time up to the age of 8. They can have new signal changes. They can have enhancement. So don't mistake that for um, gliomas. And here's a more normal or usual look of a mature cerebellar tuber where you can see there's some retraction here and calcification with low signal in the T2-weighted sequence. Dysplastic cerebellar gangliocytoma is sort of a mimic of a malformation. This is rarely seen in the pediatric population. Actually, the mean age is about 34 years, but can be seen rarely, probably more in the second decade of life. Now, 60% of these have this typical appearance where we see this striated or tiger-striped appearance, which I think looks like a citrus fruit of some kind. 20% of them are associated with PTEN mutation. A third of them have Cowden syndrome, so they need genetic evaluation. On to regional malformations. Here, I want to spend a little time on the Dandy-Walker malformation, but first review the embryology. At this point in time, 5 to 13 weeks gestation, there's a lot of action happening in the posterior fossa. The chorial plexus has inserted into the back of the brainstem and is separating an anterior and a posterior membranous area. The cerebellar vermis should grow down and incorporate the anterior membranous area, leaving the chorial plexus right at the edge of the lower cerebellum. But if this doesn't occur due to a problem with the roof plate or especially the rhombic lip, then you get the Dandy-Walker malformation where the vermis is underdeveloped, especially inferiorly. We have tegmental vermian angle elevation. We have a persistent anterior membranous area, and the telechoroidea and chorial plexus are displaced down and out. Later, if all goes well, you have an evagination of the posterior membranous area, forming this temporary Blake's pouch, which should perforate and form the foramen Magendie. But if this is delayed or does not occur, you can have a Blake's pouch cyst, where you have an uplifting of the tegmental vermian angle, usually less extensive than in Dandy-Walker malformation, although that's quite variable. And the chorial plexus here is located at the lower margin of the cerebellum rather than being displaced down and out, as we see in the Dandy Walker malformation. So we all learned originally that the Dandy Walker phenotype is agenesis or hypogenesis of the vermis with counterclockwise rotation, a massive fourth ventricle, and a very enlarged posterior fossa malformation with especially torcular elevation. But the latter two have since been abandoned as diagnostic criteria, as these are quite variable, not entirely sensitive or specific, and really just represent the degree of which CSF is getting out of the fourth ventricle or lack thereof. And so the new real criteria is hypoplastic vermis inferior severity gradient, counterclockwise rotation. There's a tail of tissue, which is the unpaired caudal lobule coming off the lower margin of the vermis, an obtuse vestigial recess, look how flat that is, and a chorioplexus and telochoroidea displaced infralaterally in concordance with the known embryology there. So, this is where the telochoroidea and the chorioplexus belong, kind of up and in rather than down and out in normal scenarios. So we no longer care about the torcular, just to reiterate that point. So let's talk about the anatomic relationships of the choroidea, choroid and telochoroidea. The telochoroidea is a vascularized membrane of pia and ependema. It really kind of houses and gives rise to the chorioplexus. It runs in the inferior medullary velum, and it should kind of be a surrogate marker for where the chorioplexus lives. So in the parasagittal plane, you can see it heading up and in, and in the axial plane, it heads medially here and forms this V shape. Looks just like that on imaging, with the white arrow being the telochoroidea and the lumpy, bumpy black arrow here, the chorioplexus. And here's a past specimen showing the telochoroidea looking through the foramen magendie. We can also see the same thing on high resolution ultrasound, the end of the second, beginning of third trimester. As the vermis grows down, it incorporates the anterior membranous area, leaving the chorioplexus right at the margin of the cerebellar vermis here, as opposed to in Dandy Walker malformation, where again the chorioplexus is displaced down and out and really outside the dilated fourth ventricle, not seen in midline, versus Blake's pouch cyst, where you can see chorioplexus at the lower margin of the vermis in midline and protrudes into the fourth ventricle. So ultrasound can be useful sometimes in these cases. Note, as the cerebellar vermis is growing, it's also changing its shape. And look at the marked change in morphology between 15 and 16 weeks gestation. It's this point in time that the rhombic lip becomes incorporated into the lower margin of the vermis, shaping the vestigial recess into a sharp kind of point here. So it's now thought that Dandy Walker malformation and Vermean hypoplasia exist on a continuum where, the whatever cause that leads to this abnormality will really kind of bear itself out in the imaging phenotype there. Now, sometimes you can have these ambiguous phenotypes that can be difficult to sort out. So here's a fetus at 36 weeks, sagittal midline, parasagittal image. We can see what we called a a Blake's pouch cyst. There's a mild tegmental-vermian angle elevation, kind of borderline size of the vermis here. Of course, the cisterna magna looks enlarged, but the telochoroidea is displaced infralaterally. So this should be a Dandy Walker malformation rather than Blake's pouch cyst. And here this was proven postnatally. We have some mild deficiency of the lower vermis, telochoroidea and chorioplexus displaced down and out, leaving this to be the anterior membranous area, and the tail of the vermis being plastered against the lower margin of the cerebellum here, Dandy Walker phenotype. On the other hand, if you can identify tela and chorioplexus going up and in where it should, then that should exclude effectively a Dandy Walker malformation. Not that it's really a diagnostic dilemma. In this case, we see a fairly sharp vestigial recess here. There's the tela, there's the chorioplexus. So these are cases of Vermean hypoplasia. So again, helping to exclude Dandy Walker malformation. So to review some of the cystic posterior fossa anomalies that we might see, here in this case, we can see an asymmetric enlargement of the retrovermian cisternal spaces and some flattening and mass effect upon the left cerebellar hemisphere. This should be, an arachnoid cyst of some kind. There's also incidentally thickening of the lower tectal plate. In the second case, we can see that the cerebellum and the brainstem are normally formed and not displaced. We see duplication of the falx cerebelli and an enlarged cisterna magna. This is what you would say is a megacisterna magna, which is a diagnosis of exclusion, should not have hydrocephalus and normal appearance of the posterior fossa parenchyma otherwise. In this case, we can see that there's a mild elevation of the tegmentovermian angle, and the choroid plexus here is heading up and in. So this is a Blake's pouch cyst, versus this case where we have more increase in the tegmentovermian angle, a flatter fastigial recess, and choroid plexus displaced inferiorly and laterally. This is Dandy-Walker malformation. And finally, we have lower vermian deficiency and tela, choroid plexus heading up and in. This is going to be vermian hypoplasia. All right, another entity that is often misdiagnosed as Dandy-Walker malformation or vermian hypoplasia, especially on fetal MRI, is this disorder. So here we can see on the fetal case that there is vermian hypoplasia, but it looks more superior than inferior predominant in this case. And now, when you see this, you want to go to the parasagittal plane and look for thickened, horizontally oriented superior cerebellar peduncles. This is the signature feature of Joubert syndrome and the sagittal correlate to the molar tooth malformation, that we talk about in this disorder. And we can see that that can be very difficult to see on fetal MRI based on resolution or just even the plane of imaging there. So the parasagittal plane, very important to evaluate. Also, realize that many of these will have dysgenesis and kind of disorientation of their fissures and folia in the superior midline cerebellar region, as we can see here. So that is also a feature and can be seen in a high number of those patients. Of course, if you do DTI, we don't see crossing fibers of the superior cerebellar peduncle in the midbrain here. Those would be in red, so they are absent in this disorder. And so sometimes the superior cerebellar dysgenesis can be seen even without the molar tooth malformation. This is a ciliopathy, which is important for midline crossing of white matter fibers. Speaking of molar teeth, there is sort of a differential for that. It's not just a slam dunk Joubert malformation without any other information. Both of these patients have the molar tooth malformation. In this case, there's the peduncles are a little bit thinner than in the inferior case. But if you do DTI, we can see there's no loss of the decussation of the superior cerebellar peduncles here. We can see the red hue here in the midbrain versus the lower case. So the lower is Joubert syndrome, and this is another genetic disorder, the Peretti-Bolt-Salzer syndrome, which can also see cerebellar cyst in this disorder. In this case, we have a patient that presented with scoliosis and horizontal nystagmus. Now, these images really make the diagnosis, and this is what's called the split pond sign and the butterfly sign of the medulla. So when you see that, this is really what's called a Robo3 gene mutation or gene variant in the setting of horizontal gaze palsy with progressive scoliosis. Um, Now, together, again, the split pond sign and the butterfly medulla are diagnostic. So this is an autosomal recessive disorder. It's caused by the Robo3 that leads to impaired axonal guidance with disruption of normal decussation of selected axons. So you can do DTI, and you can see that at the level of the midbrain, we don't see the crossing superior cerebellar peduncle fibers like we should. And in the medulla, we don't see the decussation of the pyramidal tract. So we can see everything looks blue here. If you look, this is a histologic specimen, so the corticospinal tract should decussate here and head out to the lateral corticospinal tract. So we might expect to see the fibers here running in green, anterior to posterior, or kind of lower down, maybe in red here as they're crossing left to right. But we don't see either in this case. So DTI is also useful to help make the distinction here. Some other regional brainstem malformations. These can have a very similar look on fetal MRI and can be difficult to distinguish. This is a case of a pontine tegmental cap dysplasia where you can see this bump coming off the back of the pons here. Here's a frank brainstem disconnection syndrome where there is complete or near complete loss of tissue, between the brainstem components here, and also, cerebellar hypoplasia is a component of both disorders. So here's a case from fetal MRI, and you can see how it resembles both the pontine tegmental cap dysplasia on some images and brainstem disconnection. Can be difficult to make the distinction. Many of these can be due to some disruptive process, but a lot of them are sporadic and of unknown origin. So here's another case where you can see that the entire brain looks hypoplastic, especially the pons and cerebellar vermis. And if you look closely into the infralateral cerebellar hemispheres, you can see what looks to be gray matter heterotopia. So this is some bright signal in the T1 following gray matter signal. This is cerebellar gray matter heterotopia. Looking closely for other abnormalities, we can see that there is a cleft in the clivus that should not be there. The olfactory bulbs and tracts are absent here, and we can see these fluid levels in the nasal cavity. This is a sign of choanal atresia. So together, this makes a very strong case for charge syndrome, and that's what this turned out to be. I like to think about this as CAE syndrome because that's what we see on brain imaging. We see you may see colobomas, atresia of the choana, and the ear abnormalities. But also remember this eponym called echo. And now these are the most common things that you'll see in charge, over 90% each. So these are the ear abnormalities, so semicircular canal hypoplasia, cochlea hypoplasia, and then you can see clival clefts in over 90%, hypoplasia of brain structures, and hypoplasia of the olfactory apparatus. So these are really strong features of Charge syndrome, and you should also look for those in addition to what we conventionally think about for Charge syndrome. Why do we see cerebellar hypoplasia and heterotopia in Charge syndrome? Well, it turns out the CHD7, which is the variant there, in most of these cases, is important for FGF signaling, and so cerebellar growth, for granule cell proliferation, again, for cerebellar growth. And when you don't have it, there's downregulation of renin. Now, the external granule cells communicate with the Purkinje cells, and the renin is important for migration. So often, you'll see the heterotopia, and these may be clusters of Purkinje cells that didn't get out to where they need to be. Finally, diffuse malformations. So this is kind of a common problem that comes up in fetal MRI. What do you do when you have kind of widespread brain underdevelopment malformations and a Z-shaped brainstem? Well, there are two primary differential considerations, and that is dystroglycanopathy and tubulopathy. So we can look for other things to help sort that out. If you see a very severe um, Z-shaped brainstem, if you see lack of the aqueduct, what looks to be marked hydrocephalus, very thin cortex, and cerebellar malformations where you have like irregularity of the cortex and cyst formation, think dystroglycanopathy. If not, you could be dealing with a tubulopathy. They usually have uh, less advanced Z-shaped appearance of the brainstem, and look for malformative asymmetry. So you can see that the pons is hypoplastic, but asymmetrically so, as is the cerebellum. And the latter can be, give you the appearance of this sort of tilted telephone receiver sign that we see and talk about in Facey syndrome. But in that setting, usually the cerebrum is less, affected. The other thing is you want to evaluate the orbits, because those can help give you clues. But just to reiterate, the cobblestone cortex of dystroglycanopathy, the union of the basal ganglia and the tubulopathy and the arterial abnormalities in Facey syndrome are very difficult, if not impossible, to evaluate on fetal MRI. And so you really want to pay close attention to the posterior fossa structures to help differentiate these disorders. And again, ocular globes are often affected in dystroglycanopathy, may be affected in tubulopathy, although are often spared in my experience. And if you do see sparing of the ocular globes, think about tubulopathy if you see a Z-shaped brainstem. And finally, just the last case, just to reiterate that torch infections can also cause malformations of the cerebrum or cerebellum if they occur in the right point in time during neuronal migration. And here is a 37-week fetus with a normal sagittal midline T2-weighted image and an axial T2-weighted image. Red is normal. Although, is it truly normal? We'll come back to that. Looking in the parasagittal plane, we're seeing a caudothalamic groove, germinalytic cyst, and cystic change in front of the temporal horn of the lateral ventricle. Together, this is very classic for a torch infection CMV. And looking back at the cerebellum, when you compare it to an age-matched normal, it looks a bit misshapen. And actually, postnatally compared to age-matched normal, we do see irregularity of the fissures and folia here. Kind of have this, eh, sandstone or sandpaper type appearance. So this is consistent with widespread malformations that can be difficult because they're symmetric in their appearance. So this is CMV infection. Okay, so I hope this has been helpful. And to review, I'd like to classify hindbrain abnormalities based on whether the dominant finding is hypoplasia, hyperplasia, or frank malformation. Then consider the differential diagnosis based on diffuse, regional, or focal abnormalities. Here are my references. And I thank you very much for your time and attention. I really appreciate being asked to come here and talk to you guys. And I hope you have a wonderful day. Feel free to email me any questions.